40-year-old female patient with left finish
eye
this. Okay.
proptosis. Okay.
Mm.
Okay, this is the
يلا. 10-year-old female
okay.
patient with neck masses. Request control, please.
Okay, sir. Sir,
Mm. Request control.
yes, sir, I have requested. Sir, I have requested.
Yes. Go on.
Okay. This is an MRI, multiplanar, multi-sequential MRI of an adult female patient presented with swellings in the neck, in which I can see that first one is the coronal T2 FATSAT image, in which I can see that there is evidence of multiple hyperintense, well-defined, ovoid to rounded lesions noted uh, predominantly in the interior, starting from interior, extending up to posterior cervical chains. Um, the more larger one on the left, on the right side. There is also evidence of a well-defined similar intensity lesion noted in the I guess this is abutting the rectus spinae muscles also. But I would like to confirm these on the orthogonal views, for which I would like to select axial T2 fat side image, sir, if you allow.
The mouse. Leave the
Okay.
mouse. Mm.
Okay, this is axial T2 fat side image of images of the same patient, in which there is re-demonstration of the cystic or hyperintense lesion, as I mentioned earlier. They keeping in view, they are well defined, and there is no significant perilesional architectural distortion or any significant fatty strandings. So to me, they look like some benign pathology, but I would like to confirm it on post-contrast images for further characterization of the lesions. Okay, this is coronal T1 FATSAT image. Um, this is showing certain post-contrast enhancement. Um,
Mm.
so basically, these are benign lesions. I would like to keep the differential of enlarged lymph nodes versus some bilateral branchial cleft cysts.
Mm-hmm.
And the possibility of venolymphatic malformation is also there. But I would also compare
Are
it
you
with
sure,
previous.
doctor?
Uh,
Doctor, are you sure? Are you sure?
sorry,
Look here.
sir, these are benign looking lesions, and just these are the differentials are in my mind up till now.
Okay, okay, but look
Uh,
here. Have a look here again. Here,
okay, sir.
especially here. Have a look here. Look at these slides.
Look at
What
the.
happened? Look at these slides. See? Here.
Okay, sir.
What happened here?
Mm,
No, no. See. I give you what happened here.
okay, sir. Uh, so this is exerted fat set image.
Okay. What happened?
What happens, sir? There is some thickening of, I guess this is sphenoid uh,
Okay.
bone, and
Mm.
there is a sphenoid area asymmetrically, which is asymmetrical. Basically, there is
What's
thickening.
mm, what's your differential
Right.
diagnosis?
So it can be
Mm.
malignancy of the sphenoid bone with the large metastatic lymph nodes.
Okay.
Um,
Mm.
but I would like to see if there is any definite bony involvement on CT images if provided. Uh,
Give me your differential diagnosis.
Sir, differential diagnosis based on this. This is the malignancy of the sphenoid region, sphenoid bone with metastatic lymph nodes.
This is sphenoid. We are extra. What is the name of this region, doctor?
Um,
This region. Hmm. Again, I will show you something.
yes,
What is this region? This is the sphenoid. What
yes, sir.
is the name of this region?
Name of this region. So I have completely blanked now.
No problem. Part of the nasopharynx.
Okay, sir. Fossa of Rosenmuller.
Yes, excellent. What
Yes,
happened
sir.
here? What happened? Yes,
Yes,
you
sir.
are right. Hmm.
Yes, sir. This is the thickening and thickening of the fossa of Rosenmuller, which is most
Excellent.
likely the source of these metastatic
So give
lymph.
me a reasonable differential diagnosis here.
So it can be squamous cell carcinoma involving the fossa of Rosenmuller with these metastatic lymph nodes in cervical
Excellent.
chains.
Excellent. 50-year-old male patient with severe
The time is up.
ophthalmologia. Okay, thank you, doctor,
Okay.
so much. You did very well.
Thank you, sir.
Uh, Doctor, you start amazing startup, and then you didn't wait to see and to يعني search the rest of the examination like I advised you from the first to the last slice. It is
Yes, sir.
impossible to this very large, huge, amalgamated, bilateral, globular shape lymph node to put in your first diagnosis is a benign. Okay, I'm not against your diagnosis, but it
Yes.
should not be in the top. Second point, take home message for all of you, my colleagues. Any cervical lymph nodes, be sure that there are something hiding behind it. Even either, sorry, from the nasopharynx, like here, this is asymmetrical soft tissue thickening of the nasopharynx, nasopharyngeal carcinoma until proof otherwise, or from the lung, anything, cancer, TB, infection, whatever.
Mm.
Cervical, cervical lymph node is like a comparse in cinema. There are a transient station for the major boss, from where the major boss will come from the nasopharynx, mainly from the tongue,
Yes.
maybe from the tongue. This is the neck. Least likely from the larynx. I'm talking about يعني, my experience. Or from the chest, from the especially TB. Very common in our practice that some patient come complaining of large cervical lymph nodes, and it lastly the pathology in the chest. Okay, my colleagues, what
Thank you,
is
sir.
welcome. What is the moral from this case? Consider the cervix, cervical lymph nodes or the neck lymph nodes as a comparse. Don't trust in them. They hide in the big criminal person either in the nasopharynx or the tongue or the chest. Very critical for all of us. Second point, the lymph nodes are not necrotizing. Okay, doctor, why? This is a nasopharyngeal carcinoma. No problem, but at least you pick up the pathology. Thank you, doctor, so much. Next patient,
Thank you,
sorry,
sir.
next candidate. Next candidate.
Assalamu alaikum, sir.
Salam, 50-year-old male patient with severe ophthalmoplegia and diplopia for 7 years, 7 days. Take care. This history is tricky. Yeah, go on.
Okay. These are sagittal T2 weighted images of a 50 years old male patient in which there are heterogeneous intensity areas are seen within bilateral intraconal extraorbital soft tissues, particularly more on the left side, on the right side, in which I can appreciate there's also some preorbital soft tissue thickening. The muscles are swollen on both sides.
Yes,
There are some, sorry.
yes. Excellent,
Uh,
excellent. Go
the,
on.
there is the muscles are quite swollen, and they are boggy. And next, I would like to see the cavernous sinus of this patient. The cavernous sinus region is also showing some soft tissue intensity region,
Right
particularly
or
on the
left,
right
doctor?
side. Right,
Yes,
right
excellent.
more, right
Yes,
more.
excellent.
ICA, it is a butting ICA on the right side, but not
Yes.
obliterating its lumen. But I would like to confirm the finding in other sequences as well. There is post-contrast enhancement as well in the same region which was showing soft tissue area, and there is heterogeneous type of ill-defined enhancement in both bilateral extra orbital intraconal region. There is some dural enhancements adjacent to the temporal lobes of brain.
Yes.
I suspect that it could be yes, there are bilateral orbital swelling in this coronal image. I can appreciate. So I would next my suspicion are on the line of some autoimmune disease or pseudotumor. And next I would advise the thyroid mm, to see any thyroiditis, any history of autoimmune thyroiditis or autoimmune diseases. And so this is my diagnosis that it is most
What's
likely
your other
orbital pseudotumor.
differential diagnosis?
Other
Mm-hmm.
it it could be um,
By the way, you are correct. But why this is not a thyroid or biopsy?
sir,
Why?
because it is the there was a differentiating point. It is there's no there's cock bottle sign, and I cannot appreciate it. The individual muscle bellies are not swollen, but there is an extra muscular soft tissue.
No, but here's no. Why? This all the muscle are swollen. How come, doctor? See, all the muscle are swollen here.
Mm.
Plus the extra muscular soft tissue. What make you are correct by the way, but what make you to exclude how to exclude thyroid or biopsy?
Uh, Sir, I have forgotten. Maybe this cavernous sinus enhancement, thyroid one
Excellent,
doesn't involve it usually.
excellent. What else? There are something
Um,
here. Here there are something. Here there are something. What is
there
this?
is some
What is this?
lacrimal gland. Lacrimal glands are
Excellent.
involved bilaterally as well. Yeah.
Bilaterally. This is common in thyroid or biopsy or autoimmune
Autoimmune
pseudotumor.
pseudotumor.
Excellent.
Yeah.
Thank you, doctor. Really, you are amazing because
Thank
this
you, sir.
case is very tricky. Why? From the first look, there are diffuse bilateral enlargement of the muscles, and there are some Coca-Cola sign, really. But here only, here lost. The doctor takes the examination collectively. There are here soft tissue abnormality in the cavernous sinus, which confirmed the right cavernous, confirmed by the post contrast here. Okay.
Mm.
And then she
Sir,
you forget to tell me about the lacrimal gland, but your answer is correctly, your diagnosis correctly, correct. Really, this is a pseudotumor, idiopathic orbital inflammation. What, doctor, could you tell me what syndromes or what is the underlying associated pathology? Because it is bilateral and symmetrical. There are common syndrome. Do you know it?
sir, I don't remember it. It is IgG related, what I can remember.
Excellent. IgG4. Yeah, excellent. IgG4, which commonly associated with autoimmune thyroiditis, uh, retroperitoneal fibrosis, cholangitis, and all of this autoimmune pancreatitis. More than excellent, doctor. You did very well. My colleagues, this is one case of very tricky case of because it is very symmetrical, bilateral. When I see this case is the first time, I put thyroid or biopsy in first diagnosis in my list, top my list. Okay, then I replace it by tumor, pseudotumor, because of this cavernous sinus and lacrimal gland. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Yes, sir.
doctor.
45-year-old male patient presented with pain in the right orbital region. Why I'm concentrating in the orbital? Why? For two reasons. First, most of us not familiar with it. Second, it may come not only in head and neck. One examiner may bring one CT, brain examination and the pathology in the orbit. Maybe in a neck normal cervical MRI, and there are aside film finding in the orbit. Very important to look at the orbit. Go on, doctor.
I'm presented with axial sections of CT scan of the brain and the soft tissue window of 45-year-old patient presented with right orbit pain. I want to check the cut from the first to the last one before conveying my finding. I want to check the paranasal sinuses. The maxillary sinuses are well aerated. Frontal sinuses are well aerated. There is no soft tissue mass can be seen or opacification. I want to check the ethmoid air cells as well,
Yes.
as well as the orbital wall for the presence of any destruction or bony lesion. The ethmoidal air cells are normal. There is no opacification. I want to check the orbit wall and orbit content. Here in this
Yes.
section, the skull base appears to be good. There is the mastoid air cells are well aerated as well. In addition to the sphenoid sinus. So till now I couldn't detect any obvious abnormality. So
Are you sure?
and
Look at the right, please. What
in
is
the right,
yes? What is adjacent to the mastoid air cells?
sorry, sir, what was your question? I didn't hear it.
You talk about mastoid air cell. This is very good. Talk
Yes.
about its neighbor.
Yes, both mastoid air cells appear to be symmetrical, and there is no fluid density or opacification of the mastoid air cells. But there is resorption of some of the septa, both mastoid air cells.
Mastoid air cell are okay. Look at the neighbors.
Okay. There is a lytic lesion that occupies the right petrous apex.
Excellent.
That has a well-defined margin causing bony erosion, and it has extent, yes, and has continuity with the middle cranial fossa. There is spots, yes, there is foci of calcification within the lytic lesion.
What's your differential and what's your next step?
My differential diagnosis to the lesion located in the petroclival area, which is the lytic. First differential diagnosis is
the petroclival area. The petroclival area is good. This is the petroclivus. Yes. This is the apex. Okay.
Okay. So lesion of the petrous apex.
Sorry. See, to be accurate, this is the petroclivus. Okay. This is the petroclivus. Yes. So we are talking about the apex. Yeah. What will you do next?
Apex. First, the differential is petrous cephalocele. The second differential is cholesterol granuloma.
Okay. What's your next step?
MRI of the brain.
Thank you. This is MRI. Go on.
So this is the complementary MRI in T2 sequence of the same patient. Shows a heterogeneous signal intensity lesion in the right petrous apex, which has continuity with the Meckel's cave, as I think.
Yeah.
Okay. The lesion has low signal intensity in T2, surrounded by fluid signal intensity. So I want to correlate with other sequences if available, like T1 or T1 post contrast, please.
This is diffusion.
Okay, this is the diffusion weighted sequence.
Yes.
I can see a focus of restricted diffusion at the same location. Yes. So being a petrous apex lesion with the restricted diffusion, I can put the differential diagnosis of cholesteatoma as well.
What else?
Other differential diagnosis would be epidermoid, but it is yes, the differential diagnosis could be that of cholesteatoma or epidermoid cyst as the lesions causing restricted diffusion.
Okay. What is the name of this sequence?
This is the okay. This is the heavily. No, this is not heavy T2. This is diffusion.
No.
Not
This
diffusion.
is T1 fat set.
T1. Okay, and the
Yes.
T1 fat cell, the lesion is not suppressed, and the lesion is
Yes.
stands as bright.
See, the CSF is black, and the fat is black. Okay, so it indicates which content here.
That the lesion does not contain fat because it is not suppressed on fat.
So final diagnosis.
I'm thinking about cholesteatoma, right petrous apex cholesteatoma.
Thank you, doctor, so much.
Thank
You
you.
did very well. But my advice to you, all my colleagues, when you are speaking, please, if you tell something is normal, it should be normal. If you
Yes, you are.
told the examiner, I couldn't find any normality, this means you revised and search well. Why? I give you a bone window. So, يعني biology, it must be a bony lesion or something well picked up from the bony
Bone
window.
window. Yes.
Yeah. See, I made a mistake before with one during some session that the examiner gave me some one X-ray, and I didn't pick up anything. He tried to help me. If the examiner gave you examination, it must contain any pathology. Okay, and this is a bone. So this means something in a bone. Okay. Second, compare. Especially in skull base, there are a golden rule. Compare right by left, right by left, right by left, right by left. Especially in skull base, the lesion will not pick up without comparison. Okay. Second point, this lesion is not extending to the Michaelis cave. If it is extended to Michaelis cave, it is another possibility, another pathology. It may be trigeminal pathology. It is located in the apex, confined. What is this? I think this is the cavernous, or this is the Michaelis cave itself. It is displaced anterior in comparison with here. Why? Because see here the artery ICA also is displaced anterior. So it is an petrous apex lesion. Differential diagnosis containing cholesterol granuloma, cholesteatoma, and petrous epicytes. Doctor, it is not clear. Okay, both as a differential diagnosis. This is the MRA to rule out other related lesions, may be very far, an aneurysmal dilatation. Next candidate, are you ready?
Yes, I am ready.
Could you give me 5
Yes.
minutes, 10 minutes, please, my colleagues, because 2 hours continuously. 5 minutes, I will come again. Okay?
Okay.
This is a 5-year-old female patient, 1 day of odniphagia, ear pain, neck pain. 1 minute, one second, because they mentioned something. 1 second, 1 second. Neck pain and fevers. Yeah, go on.
Okay, I am provided with the axial post-contrast images of the face and neck region. No, I'm trying to scroll.
Let me scroll for you.
Okay, thank you, please.
Go on.
Um, the visualized vascular structures appear unremarkable. As far as I can see, both parotid glands appear normal. I
Yes.
can, sorry, again, up, please. I can see heterogeneous. I can see heterogeneously enhancing soft tissue lesion on the left side of the pharyngeal region,
Okay.
which is causing mild mass effect and
Excellent.
narrowing of the airway.
Excellent. What else? Go on. One second. Okay. What happened here? What happened?
There is a prevertebral
No, don't worry about it.
heterogeneous.
Don't worry about it. What happened here? Here. What happened?
There is a heterogeneous appearing soft tissue density lesion at the base of the tongue,
Okay, and
and it is extending inferiorly.
to excellent. Yeah. What is this? What is just below
Yes.
the base of tongue? Something closing the larynx during swallowing.
I guess it could be infected laryngocele.
Not laryngeal. Yeah. See, there are something here. Complete. You are in the right pathway. What happened here? What happened?
This is a soft tissue density enhancing lesion with internal cystic component and
And the patient has fever. So fever. So what's your differential?
this is most likely infective etiology, abscess formation.
Okay, where is the anatomical location?
And
What is the name of this? AB?
In the hypopharyngeal region.
No, this is not the hypo. This is the oropharyngeal. This is the base of tongue.
Okay.
This is the
Epiglottis.
Okay, excellent. So what's your
Epiglottitis.
differential diagnosis? Infection containing air. What is the name of infection containing air?
Name of infection containing air.
Yes.
You are asking about the involved organism, like
anything. Infection containing air. What is the name of infection containing air in the bladder, gallbladder, urinary bladder? Yes, emphysematous. So this is emphysematous infection in the epiglottis. So tell me the name. Emphysematous.
Emphysematous infection of the epiglottis.
So emphysematous epiglottitis. What will you do next? What is the most important and the most critical?
The most important here is to secure the airway, as it can cause the airway obstruction.
Thank you, doctor, so much. This is a life-saving. You pick up it well, but you hesitate in the middle. Don't hesitate. Please, my colleagues, take an advice or a moral from this case. Please walk behind your doubts. Here, there are the abnormality in the axial. Where is the abnormality? I don't know. Okay, begin from here. This is the nasopharynx. Then down, after starting the level of palate or the palate, whatever palate, we are in the oropharynx. This is the base of tongue, down, down, down. The base of tongue here, after the base of tongue, nearly just at the base and something here. Okay? At
Okay.
least tell me, doctor, this is between the oro and the laryngeo. This is containing the base of tongue and epiglottis. This is acute emphysematous epiglottitis, life-saving. Why? Because it may obstruct the airway. First step to secure the airway. Second step, this patient needs a high dosage of vancomycin and cortisone. Okay, the perivertebral space is clear. The visualized brain, the visualized spinal cord is good. Okay, so this is only limited to the epiglottis. Thank you, doctor, so much. You did very well. We should also pick up or search for extension inferiorly or to the mediastinum, but this is limited here. Second, next candidate.
Yeah, good afternoon, sir. I am candidate 14.
Welcome, doctor.
Hello.
6-year-old
Yeah.
male patient. This
Okay.
patient has some abnormality here.
Okay.
Okay.
So shall I remove request for the control or okay?
I will.
Okay. Okay.
Score for
Yeah,
you.
sure. Yes, sir. Thank
All.
you. Okay. So yeah. I've been provided with CT scan axial sections of the head and neck region or in the orbital centered over orbit. I see an abnormal heterogeneous lesion which is predominantly cystic in nature, centered over the left orbit. It is causing yeah, okay. Can you come to yeah. The lesion is hypertenuating with and multilobulated with
Yes.
low density within it. It is
Yes.
causing mass effect from a proptosis of on the left eye. I am searching for the left eyeball.
Islam.
Can you left eyeball appears to be there is an area of calcification entry to the lesion.
Where is the left eyeball? You are in the right way.
Yeah.
Run behind your
Yeah.
doubts. Where is the left eyeball?
Yes.
Where?
Left.
Can you see it?
Just this I think it's displaced anteriorly
No.
and inferiorly.
No. This is this is not the left eyeball. Where is the left
Okay.
eyeball? And
Oh,
what is this?
there is some that is metallic artifacts are there. So I think this is a case of thysis bulbi with some implant over there.
Doctor, there are no left eyeball. Okay, and
Oh,
there are
that's the
this.
implant in prosthesis
Yes.
is
So
there.
this is status post.
Status post surgery.
Excellent.
Post surgery. Yeah. So
They
there is a large
remove something.
yeah.
They remove something here.
Yeah.
Okay.
So this
And
this
then
appears to be a
after
case
this,
of
after the surgery,
exenteration.
the patient
Okay.
complain of a swelling.
Okay.
This is
Yeah.
the
So
swelling.
this is a
This
case
the
of
rest of swelling.
exenteration of orbit with the removal of some bony fragments also, and after that
Yes.
there has come a swelling in the scalp, lateral
Yes.
scalp, and also in the orbital region, which is
Give me
predominantly
final
fluid level
diagnosis,
and with.
please. Final diagnosis.
So with this
See,
post operative
if I show you 1 minute, if I show you,
yes.
or if I give you the detail of the operation, this patient did this operation, remove something from here and report this
Okay.
and report this. Could you tell me what did the surgeon remove from this left side?
Yeah, including mandible and
Yes. So he
part
removed
of
some
mandible and
malignant or aggressive mandibular region. And
yes.
yes,
with orbital, probably it was with extending to the orbit.
Okay, excellent.
Centered and mandible.
What's your opinion about resection? There are a new mass. So give me, please, your final diagnosis.
Okay.
Status post.
Can I see, sir, bone window? Want to see if any periostal.
Don't worry about the periostal. No periostal.
Okay. No periostal reaction. Okay.
This is status post.
Yeah. So I am thinking with this extensive lesion, including the mandible and also maxilla and and extension to orbit. I am thinking of any possible previous sarcoma.
Okay.
Right now, the lesion is predominantly hypodense especially in the orbital part.
Okay. What is about the new finding? What is about what is the name?
There is a scalp lesion is noted along the left frontal bone, located
and
along the
what
left
about
frontal
here?
lobe. Yeah, and
what about
this
here?
This
What about here?
This
when after resection of tumor, when we find again what is the name?
One concern is about the abscess.
Not abscess.
Because the lesion is hypodense.
This is a true tumor. See, doctor, this is a tumor.
Okay. Yeah, heterogeneous.
Yes. When the tumor come again, what is the diagnosis? What is the name of coming tumor
metastatic
again?
Metastasis.
Not metastasis.
Recurrent tumor. Recurrence of the tumor.
Excellent, doctor. Thank you so much. This is a very difficult case. Why I bring this case? Because your new Viva system gives the examiner only 12 cases for 1 hour. I think they must bring some long cases, some long cases. This patient have at least, we should tell, status post left hemimandibulectomy and the left zygomatic resection and the maxillary and the left eye or orbital exfiltration, because there are no eyeball here. Okay, there were here some malignancy or some aggressive lesion. They made all this reconstruction. Okay, this is prosthesis, not calcification. And what is the most important issue here today? To tell the examiner, I could see this is a soft tissue, my colleagues. This is a soft tissue. Nodular, enhancing, irregular. So this is recurrent. If you tell the examiner, doctor, this is status post. See here. This is not the muscle, the tragoid. The tragoid. This is the tragoid. I think this is the recurrent tumor and infiltrate the soft tissue of infratemporal and the fossa here. So this is a recurrent malignancy. Due to the removal of the mandible, it may be a myeloblastoma, whatever. By the way, this is a recurrent malignant myeloblastoma, but at least we should tell the examiner about the details and the logic differentiate. Thank you, doctor, so much. It was very difficult.
Sir, one more thing. What about the lesion in the scalp along that frontal bone, frontal scalp?
I think it is separated from the original or from the bed of the surgery. Okay.
Okay.
It is separated. It is. I think it is another entity. It may be
another
something metastasis.
pathology. Okay.
I think it is. I will put the answer in our group.
Yes,
but the most important to focus in the recurrence and the status post-operative. Next candidate, please.
Yeah. Thank you, sir. Thank you so much.
Hello.
Welcome. Hello. Welcome.
Hello.
Yes. Hello. 55. Yes. Welcome. 55-year-old male patient. Fever, sore throat, dysphagia, chest pain.
Okay, these are non-enhanced axial CT sections of the neck and upper chest.
Yes.
55-year-old male having history of sore throat, fever, and chest pain. Can you please scroll again? In this, in the neck region, Yeah, in this non-enhanced examination, there is thickening and diffuse thickening along the right supraglottic region, right paraglottic space,
Excellent.
ill-defined thickening. I am looking for the laryngeal cartilages. The morphology seems to be unremarkable. In the superior mediastinum and the anterior mediastinum also, I can appreciate there is thickening of the esophagus, and also there is a small lymph node in the peritracheal region, and the tracheal lumen is also elongated, and somewhat thickening is there. I will like to see the contrast enhanced imaging if available here. In this contrast enhanced imaging of this same patient, the thickening this shows the collection with enhancing walls along the parapharyngeal and the side walls and extending into the mediastinum along the tracking down into the posterior mediastinum in the
What's
form
your
of
differential?
an abscess.
What's your differential?
This is likely this is post-infective abscess with its infection in the parapharyngeal space, extension from the parapharyngeal space through into the mediastinum
Excellent.
along
What will you
the.
do next? What will you do next?
As this is emergency, this an infection and through the prevertebral space is also there is involvement of the prevertebral space, so there's danger. There is chances of infection into the danger space. So I
Yes.
will inform the findings to the referring physician. I will suggest urgent referral to the um, for drainage of this patient. Also, there is I can appreciate bilateral pleural effusions. So
Okay. Okay. Before drainage, what is the most important to be secured?
yes, I would like to see the airways in this upper. Yeah, there is, as there was elongation of the airways. Yeah, also in the region of the glottis there is narrowing. So this patient needs urgent airway. I suggest urgent scleration of the airway.
Thank you, doctor,
Also,
so much.
this.
Really appreciate your style. You did very well. This is a large
Thank you.
retropharyngeal abscess extending into the mediastinum. This is not TB because the lung, you should ask me here, doctor, please. I want to revise the lung window, rule out any concomitant infection, rule out TB. Second, the bone here looks like not eroded till now. Next candidate, prepare yourself, please. Thank you, doctor, very much, very much. You did very
Thank
well.
you.
I think there are no MRI. This is a classic case. You may be given a case like this in the exam, despite it is very clear, classic. Why? The examiner wanted to assess either you are safe or not. Take care, my colleagues. It's better to tell the examiner it is retropharyngeal abscess associated with mediastinitis, life-saving, need drainage. All the examiners need buzzwords. All the examiners. Okay? Thank you so much. Any
Thank you.
candidate are ready?
Yes, sir, I am ready. Candidate number 19. Good evening, sir.
Okay. Good evening. 1 second, please. 1 second. Sorry, my colleagues, because your list is too long, I prepared 2 lists of cases. I'm preparing the second 25 cases. Okay? Yes. 55-year-old pain, left facial swelling, pain, and paralysis. One second. Lose this. 1 second. Leave the mouse. Leave the mouse. Yes. Go on.
Yes. Yes. Here I am presented with the non-contrast CT scan images, soft tissue window,
Yes.
axial sections.
Yes.
Here I am scrolling from the whole set of the images, and then I will quickly communicate my finding.
Hmm.
Here I can see that there is a soft tissue density lesion is there along the left buccal space, and that is causing the destruction of the body and the ramus of the mandible. There is areas of erosion as well, and there are pockets of air are noted inside it, and it's also extending till the ramus of the mandible and uh, uh, ramus of the mandible, and there are areas of hypodensity within it, so they are suggestive of the collection. I will check the bone window for the bony details. So from this imaging, it's looking like the osteomyelitis of the mandible with abscess formation. I will check the post contrast images as well as the full set of the images, coronal images and the sagittal images as well.
1 second. 1 second. 1 second. This is the corona. 1 second. Yeah. Go on. Let me scroll for you. Let me scroll.
Yes. Sir.
Yeah. Go on.
Yes, here I can see that the lesion, the lytic destructive lesion, there is a tooth is also present inside it, and there is a caries are also noted within the lesion. So that is the source of the infection that leading to the osteomyelitis of the mandible and formation of the abscess. And I will also check for any soft tissue sinus tract that may be present for the by the full set of the images.
Yeah.
Please scroll
Yeah.
the full set of the images.
Do you remember? Do you remember the history? Patient didn't have any fever.
Okay.
Hmm.
So then the other differential, it can be due to the post, if there is a previous history of radiotherapy is there, then it can be the
No
radiation
previous
necrosis.
history. No previous history of radiotherapy, doctor.
Okay.
The patient has a
Then
chronic, listen to me, please. Chronic left mandibular swelling.
Okay. So patient chronic left mandibular swelling. So it can be dentigerous cyst with
Yes.
expansile unilocular lesion is there, and tooth is present inside it. So it can be the dentigerous cyst, or
What
that
will you
can
do
be the one
next?
possible.
Sorry, what's your differential diagnosis? See here. Okay.
Another differential can be the amyloblastoma because the lesion is looking aggressive. So amyloblastoma can be the one differential,
Excellent.
and this is the classical site of the amyloblastoma that is involving the ramus of the mandible, and lesion is looking aggressive. But most of the
Okay.
time, it's the multilocular.
Okay. What will you do next?
And the
I
in
think this is
the
MRI.
next, I will go MRI imaging.
Okay. Thank you, doctor, so much. You did very well, but very important message home of today. Please, my colleague, from the beginning, you must put yourself in the correct pathway. Otherwise, you will lose your vibe. Why? From the beginning, look, the patient didn't have any history of fever. The patient has left facial swelling, and there are a new onset of trismus. There are something acute on top of chronic. He have chronic swelling, and due to maybe this fracture, he have something new, pain and trismus, whatever. So we are dealing with something chronic. Second point, tell yourself before giving a wrong diagnosis or a misleading pathway to yourself. Is this the image of abscess or inflammation? The fat planes is almost clear. Okay, the opposite in inflammation, there are extensive edema, extensive loss of fat brain, and the see here, this is the masseter, this is the masseter, very clear. Just something here, lytic here. Okay, and try to be يعني, to be not throating or not regurgitating many of the unlogic differential diagnosis, because the examiner from the first words he take an idea. Look here also, almost both sides are symmetrical except of this little bit swelling. So this is not inflammation. So think in other possibilities, tumor, other benign or malignant, no problem. But don't talk about
Can we say this
tumor.
can be bisphosphonate associated osteonecrosis? That can be one possibility.
No, why? Why? Because in the history here, this is chronic. Second point, look here, there are no any osteonecrosis. If you look to the bone, this is a lytic lesion, and there are some breach destruction here. Osteonecrosis have a characteristic. See here, osteonecrosis have a characteristic nature of vascular necrosis and the bone sclerosis, alternative bone sclerosis with bone lucency, like this. Okay? No problem, my colleagues. These sessions mainly to correct any of our common mistake, because most of radiologists don't care, not interested in neck, and all of us consider it as audit. See here in the MRI, this is not infection. Not infection at all. See here, this is a lytic cystic lesion. See, the infection, if this infection, you can't see this tissue like this, you will see extensive edema. Anyway, you did very well. It is also a difficult case. It was a mandibular odontogenic keratocyst. We should put other differential diagnosis like amyloblastoma, like whatever, aneurysmal bone cyst, whatever. But both differential diagnosis to be logic. Thank you so much. Next candidate.
Assalamu alaikum, sir.
70 years old male patient. If I told you the history, you will get up immediately the answer. So look here without history.
These
He
are
have
axial sections.
severe pain in his face.
These are axial sections from CT, PNS. There is an area of airspace specification noted in left maxillary sinus as well as bilateral ethmoid and sphenoid sinuses. Left maxillary wall appears disrupted. I will take if there is any history of trauma. And
Yes,
also
there are
are
history of trauma.
There are multiple air locules are noted. I will take the density of this this area. If this is high density, it is likely hemosinus. With multiple fractures of bilateral walls of the maxillary sinus, as well as I think zygomatic bone and inferior orbital rim. There is I will check the window if there is any extension into the skull or any extension in the intracranial fossa noted. I will also check the other images. Sagittal.
Your diagnosis, please.
So my diagnosis is traumatic injury resulting in multiple fractures involving bilateral.
What is the name? What is the name of this fracture, please?
This is tripod fracture.
Yeah. Yes. What happened in tripod fracture?
There is fractures of maxillary bone, inferior orbital rim, as well as zygomatic bone.
Okay. There are any emergency here? When when you consider a surgical or emergency here?
There is I will check if there is any herniation of orbital contents. I think there is herniation of orbital contents here. So with trapdoor appearance, I will immediately contact the referring physician or the trauma team for immediate management of this patient. Mm.
Thank you, Doctor, so much. Really, you are amazing. Thank you. This is a tripod fracture. Take care. It may come in short, because it is يعني, it is a short case. But why I bring it? Because it is surgical emergency in some cases. Why? Due to herniation of orbital content, especially see. Excellent. There are some herniation here. Okay, I think this is maybe fat rather than muscle because or part of muscle because I could detect this inferior rectus muscle. Anyway, it is a life, not a life saving. It is a saving for the right orbit because this herniation affect immediately on the whole vision process and especially on the optic nerve. Why? Because the optic nerve is in the center. Any movement, or any imbalance for the orbit will move it. So it may be injured. Thank you, doctor, so much. Tripod fracture is a zygomatic-maxillary fractures. So remember, tripod fracture is zygomatico means zygomatic arch or zygoma. Okay, maxillary means maxilla. Okay, my colleagues, any other candidate is still waiting or remaining? Anyone didn't
No,
take
sir.
his chance? Yes?
I think list is completed. No one
Okay,
is
Dr.
there.
Akila, did you examine? Did you take a chance or
Uh,
not?
yes, sir, I do.
Take another case, Dr. Akila. You did a lot of effort along the whole week.
Sorry?
Take this case. You
Okay.
are doing a lot of effort for this group, so we must give you some additional case for you. Okay?
Okay, sir.
One of the nice cases. Let's start.
Okay, I'm provided with grayscale axial image of the thyroid region.
Yes.
Here I can appreciate on the left side there is hyperechoic lesion posterior to the left lobe of thyroid, adjacent to the carotid vessel.
Okay.
It is appearing hyperechoic to the thyroid parenchyma, and I cannot appreciate any blood flow level or any calcification or cystic component.
Excellent. Where is its location?
It's located posterior to the lobe of thyroid in the
So,
parathyroid location.
what
So
will you do
it
next?
could be a parathyroid. It could be parathyroid adenoma, measuring 18
Excellent.
into 7 millimeter, and I
Excellent.
would suggest lab correlation of parathyroid hormone and calcium levels, and could
Excellent.
also do according to the symptoms of patient. We can go for the either a nuclear scan, or we can go for the X-ray hand or like if any
What
symptoms.
nuclear
Yes.
scan do you want?
I think there are dual scan. We can do it with the MIBG and technetium, and then subtraction image to see the parathyroid.
Are you sure MIBG or something
No,
else?
sorry, so not MIBG. Actually, maybe scan, maybe scan. That we do for heart and
Maybe scan. System maybe scan. Okay. Excellent.
system maybe. Yes, system maybe.
Okay. This is the system maybe
Yes.
scan. This is
Yes.
20 minutes. This is 50 minutes. This is 2 hours delay. Tell
Yeah,
me.
here I can appreciate the in the delayed image. I can appreciate two areas of still tracer uptake, more on the left side, as we see in the on the ultrasound as well. So these suggest confirm the finding of parathyroid adenoma, and patient might have symptoms related to the hyperparathyroidism. And I would convey my finding to the clinical team and would refer the patient for to endocrinology for management of symptoms.
Amazing, Dr. Ed. Last question to get the full mark. If I ask you to do one X-ray for that patient, where, and why? Where,
One X-ray.
what?
You're asking for one X-ray, which should be
One
done.
X-ray. One location to be underwent an X-ray.
Mhm. I think
Which
mostly we
part?
see
Which part of the body do you want to do an X-ray to confirm your hyperparathyroidism diagnosis?
I think hand X-ray.
Excellent. What will you find?
There are multiple things we can find on subperiosteal resorption. Most commonly seen on the radial aspect of the uh, first, second, and third phalanges, and we can also find intracortical tunneling, as well as we can see brown tumors if they are, or if there is secondary hyperparathyroidism, and we can also see, I think, calcifications may also be present in case of secondary or tertiary hyperparathyroidism cases.
Thank you, Dr. Ed. You are amazing. One of my colleagues during the Viva, the examiner show him one X-ray, only one X-ray. And I think the examiner was preparing the next even MRI or CTI. Okay. Our colleagues, within 2 or 3 minutes, he described the lesion, code differential, and tell the examiner he will do, for example, an MRI, and he told him about the finding and management. Finally, the examiner, really, this is good story. The examiner look at him and amazing, and he is, yeah, gazed too much. He wanted to ask many questions, but the candidate cut the way. Cut the way. The examiner was astonished by the frequent, fluent, full knowledge and management, and I think he gave him very good mark. Okay. So if you remember from the first session, I told you try to precede the examiner. This is very good. When the examiner trying to pull or to ask you, he is suspect. Is this doctor safe? Is this doctor know the next step well? He became in doubt. So it is better for all of us to precede the examiner, to tell what in our mind, differential management, and يعني like this, I'm sure you will get the highest. Anyone didn't take a chance today of the expected candidate? Anyone? I have 5 or 10 minutes. Anyone to want to do any practice?
Hello,
Yes, sir.
Yes.
can I have
Oh, we have to. 18 and the iPhone. Both of you want to have a practice? Okay.
Yes,
Okay,
sir.
and iPhone.
Please.
Okay, we will take in last 10 minutes, and then we will finish our great, fantastic session. I will start with iPhone.
Yes, sir.
iPhone. Okay. There is another list containing about another 25 cases. The neck really is horrible. Study hidden neck and CNS. It need a lot of effort, really. Let's start one case rapidly.
Okay.
55-year-old, inflammatory swelling in the left parotid. 1 second. Yeah, okay.
I'm presented with axial cuts of MRI of the neck of a 55-year-old patient presented with inflammatory swelling in the left parotid area.
Yes.
This is the T1 FAT-SAT sequence
Yes.
showing a well-defined hypo-intense lesion in the left parotid, in the superficial lobe of the left parotid gland,
Okay,
showing
what about of this?
this
What
is
about of this?
the diffusion sequence. There is restricted
Yes.
diffusion.
What
I'm
it
thinking
means?
about presence of abscess, left parotid abscess.
Okay.
Okay.
Very excellent. What else?
I want to correlate with T1 post-contrast, which shows regular, well-defined marginal enhancement. No solid enhancing component can be seen.
Give me another differential diagnosis.
Warthian's tumor.
No,
As the
no,
presence
no. You
of
are
cystic.
you
Or,
are in a pathway of an
yes,
abscess.
yes,
Wartin is not a differential. Yes.
Yes, you are right. I'm
Okay.
thinking about infected congenital cyst like branchial cleft cyst.
Which
Type
branchial cyst? 1
1.
second. Wow. Why? Why not 2?
2 is located anterior to the sternocleidomastoid muscle, and it
Excellent.
has a beak extension to the carotid sheath.
How many branchial cleft we have?
4 branchial cleft cyst types.
4 or 5? 4 or 5?
I'm not sure actually. I remember 4.
5.
Yes.
Because we have branchial. See, we have 6 branchial arches. In between them, 5 branchial. Thank you, doctor. You did very well. This is infected cyst, and she put a reasonable differential diagnosis. Okay, abscess, infected branchial cyst, or infected lymph node. Thank you so much. I bring this case to talk about the branchial cleft cyst or the branchial cleft at all. Welcome. Next candidate, I think.
Hello.
Yes. This group is amazing, really. They are fighting to study more. I think if I take this group to do a project, we will compete with Harvard. Okay. Fantastic group. 65-year-old male patient with painful right tongue mass.
Okay, these are contrast and axial CT images of the neck and the face, upper face region at the level of the mandible.
Yes.
Having some, I can appreciate that there is enhancing lesion involving the right half of the tongue, causing ulceration and the irregularity of the borders of the tongue. There is there is no involvement of the contralateral side. There is this mass is not crossing
What's your
the
differential?
contralateral half of the tongue.
What's your differential?
This is likely carcinoma, primary carcinoma of the tongue.
Excellent. What should you examine? What signs should you look for it in the CT? I said in the first cancer case. What should you
I'm
exclude
looking for
here?
any gingival, any involvement of the gingiva or the tongue,
Excellent.
and also for the enlarged cervical lymph nodes to see
Excellent.
any
What else?
metastatic spread, and also
What
bony
else?
metastasis. I would like to see the bone window to see any bony metastasis, besides lung window to see any lung metastasis.
And about the lung
in the current examination, sorry.
And about the lung, what should we look for? Is this mass crossing what?
No, I already said that there is no involvement, no cross over the contralateral side.
Thank you, doctor, so much. You conclude what any surgeon need, except this looks like ulcerating neck. Thank you, doctor, so much. You are impressing. Next candidate. 70-year-old male patient with hoarseness. We have 2 raised hand here. Here, candidate 17.
Yes, sir. Assalamualaikum. This is a contrast enhanced axial CT scan study in which I can appreciate the.
What's your diagnosis?
Sir, there
Patient
is
have, yes,
asymmetry in the asymmetry on the left side,
okay.
right
So
side.
your diagnosis is
Sir, I'm trying to.
patient has hoarseness of the voice. What is the name of this sign?
It is high
What?
density. There is
No, no.
one,
What is the name of this sign?
say,
The problem in the vocal cord.
Sir, anchor. I don't remember.
What is your diagnosis? What happened for this vocal cord, the left side? Where is it?
Sir, the left side is paralyzed.
Excellent.
I will
More
look
than
for
excellent.
any.
Thank you. Left vocal cord paralysis. And this is the same sign. Okay. There are dilatation of the piriform fossa. Okay. Why? Why? Because this, after the paralysis, this arytenoid cartilage directed medially and the cord laterally. So I bring these cases because this process is confusing. Okay. The cord itself lateral, but this is the arytenoid cartilage medially. So the piriform fossa dilated. What should we do next? We should examine the patient from skull base, from here down to the arch of aorta to rule any vagal injury, or because the right and left recurrent laryngeal nerve originate from the vagus. I think the thyroid may be a cause here, maybe because it has enlarged and some abnormality. And by the way, the left vocal cord is more common to be paralyzed rather than the right one because it is the longest. Okay, my colleagues, very nice session of today. I wanted to ensure every candidate has a chance or not. Everyone has a chance.
Yes, yes, sir.
Okay, thank you so much. I think we spent more than 3 hours today. I will upload the record on the YouTube channel, I think in 2 parts at least, because it is very long. Thank you so much. Hopefully we will meet next Wednesday. I wanted to apologize about for the morning or this early timing because it is out of my hand. I have a duty after 1 hour. Thank you for all. Study hard. Most of you, even all, are very eager, very active, very good. But the Viva need practice, and not it's a usual practice. It need a practice under pressure. Thank you for all of you. Have a nice day. Hopefully, we will meet next week. Goodbye.
Thank you so much, sir. Goodbye.